neglected adolescent idiopathic scoliosis and revision surgery. And patient with neglected adolescent idiopathic scoliosis is most often present with severe clinical and radiographic deformity with poor pulmonary function. And the problem with neglected scoliosis are serious deformity at both coronal and sagittal plane, chest wall deformity, poor pulmonary function. Severe spine deformity involves spine and chest wall deformity, which both need to be addressed at surgery in neglected adolescent idiopathic scoliosis. Adequate clinical and neurological assessment, radiological study, decision-making on type surgery, adequate fixation, correction of the sagittal and frontal plane deformity are essential in neglected adolescent idiopathic scoliosis treatment. And assessment by a pulmonologist is critical for this patient to fully understand their pulmonary function. The management of severe curve can potentially carry significant risk with respect to neurologic deficit, significant blood loss, pulmonary complications. There are severe surgical options. Those are posterior instrumentation, combined anterior-posterior, preoperative hollow gravity traction, intraoperative hollow femoral traction, pedicle subtraction osteotomy, and vertebral column resection. And in our experience, traction X-ray under general anesthesia is the best modality in determination of flexibility of severe curves. If the curve magnitude in traction X-ray under general anesthesia is less than 50 to 55 degree and flexibility of curve is more than 50%, we perform posterior only surgery. This is our first case 12 years ago. She had severe respiratory problem. According to traditional approach, anterior release anterior discectomy was required in this case, and now he was first case in whom we used traction X-ray under general anesthesia. Traction X-ray under general anesthesia show us is more flexibility, and we perform just posterior surgery without any osteotomy. If the curve magnitude in traction X-ray under general anesthesia more than 50 to 55 degree and curve flexibility is 30 to 50%, we perform posterior surgery with intraoperative halofemoral traction. We start to use intraoperative halofemoral traction in the neglected adolescent idiopathic scoliosis in 1999, and you should rule out cervical instability. In our technique, intraoperative halofemoral traction is first done and increase the weight gradually. Under the traction, release of supraspinous, interspinous ligaments and ligamentum flavum, and then wide facet resection are performed, and finally pedicle stabilization and correction are done. And advantages of intraoperative halofemoral traction are gradual weight increase under spinal monitorization, providing gradual relaxation and correction, no need for excessive correction maneuver with rod. And 14-year-old female patient, very severe thoracic curve, and traction X-ray under general anesthesia show us 31% flexibility, and we perform posterior surgery with halofemoral traction, and we obtain 51% correction. The other case, very severe thoracic curve, and you can see traction X-ray under general anesthesia, posterior surgery with halofemoral, intraoperative halofemoral traction was done in this case. Pre and post-op clinical picture. The other case is same technique used in this case, and we achieve very good coronal and sagittal correction in this severe curve in the clinical and preoperative and postoperative picture. In if the curve flexibility less than 30%, if there are severe kyphoscoliosis, lordus scoliosis, we perform asymmetrical pedicle subtraction, osteotomy, or vertebral column resection. You can see very severe thoracal lumbar junctional kyphoscoliosis, and now pedicle subtraction osteotomy was done in this case, and at the second stage we perform anterior support due to severe osteoporosis. Now the other case, 14-year-old, very severe thoracic kyphoscoliosis, posterior vertebral column resection was done 11 years ago. Now is the other case, very severe thoracic and lumbar curve, and PVCR was done at the T9 level, just in the thoracic area. You can see pre and postoperative X-ray, and he had 4 previous surgery. Now is very severe thoracic scoliosis. PVCR was done in this case in pre and post-op clinical picture, and very difficult case, thoracic lordoscoliosis. PVCR was done in this case. You can see pre and post-op 3-dimensional reconstruction. We achieve very good such alignment and clinical picture. And due to presence of pulmonary complication in severe neglected idiopathic scoliosis, recent trend in surgical treatment is towards posterior methods without thoracotomy, like posterior surgery with intraoperative hallopulmonary or preoperative hallogravity traction, and posterior surgery with osteotomy, like pedicle subtraction or PVCR. Traction X-ray under general anesthesia is the most valuable method in decision making. And the suggestible outcome after surgical treatment for severe deformity is a life-changing event with improvement in the thoracic height, pulmonary function, and significant effect on the cosmosis and self-image. And overall revision rate after spinal fusion in adolescent idiopathic scoliosis 4 to 25%. Now, intraoperative causes of revision surgery: pedicle fracture, dry lesion, vascular complication, neurologic complication. Postoperative causes of revision surgery: screw malposition, rate more than 50% with CT study, as infection is and can be divided acute and delayed infection. Treatment of acute infection include debridement irrigation, IV antibiotics, and if there is recurrence, removal of implant and replacement of implant with titanium if needed. The most common bacterial causes in skin flora, like Staphylococcus epidermis in delay infection, and treatment of the delay infection include debridement, irrigation, IV antibiotics, remove all implant if there is recurrence. Today, the duration of antibiotic treatment is controversial in the delay infection. This is complication case. We have performed anterior surgery, selective thoracic fusion in this case. Now is case 1 level pseudoarthrosis, and we did just posterior 1 level fixation and graft augmentation. The other case, simple, we have performed cop-to-cop fusion in the Lenke type 5 curve. 1 year later, we saw lower instrumented screw is losing, and 1 level pseudoarthrosis, and changing screw and graft augmentation was done in this case. And this complex pseudoarthrosis, as you can see, posterior and anterior, very complex pseudoarthrosis cases. We did anterior and posterior combined surgery in this case. And the other case is acute infection and the resistant and recurrence infection, and complex pseudarthritis coexisting with deep and persistent infection. We remove all implant, and then we have performed anterior surgery due to 3-level pseudarthrosis. Post-surgical iatrogenic round kyphoscoliosis scoliosis. She had 4 previous surgery at another center. Now, first stage pedicle subtraction osteotomy was performed at the T7. Second stage, the other pedicle subtraction osteotomy at the L2 level, 10 days after the first one. Is the late neurological deficit due to metallosis, as you can see metallosis around the first generation 3-dimensional implant. And the screw malposition is very important. Now she had partial neurological deficit, and remove and change screw, and then is recovery neurological deficit. And the other case is a wrong selection of fusion level, is shoulder imbalance and trunk shift of the body, and you can see revision and vertebral body is coronal sagittal balance. And poor outcome can be seen in poor patient selection for initial surgery, wrong initial diagnosis, wrong or inadequate surgical procedure, technical errors, and complications. And adequate clinical and radiologic assessment, decision-making of definitive surgical procedure, adequate fixation, presence of various modular instrumentation system, and excellent quality spinal imaging in operating room, restoration and maintenance of sagittal alignment are important in revision surgery. We would like to see you in Istanbul for IMS meeting next year. Thank you very much.
Thank you, Osmi. We have just a few minutes left for the remainder of this session. If anybody has any questions for the speakers, please move to the microphones. Anybody have any burning questions? Yes, sir.